Hello and welcome to another episode of the Mini Battle C series by Athens Soldier Course. My name is Manos Brilakis and I am the head of the organizing committee of this course. In less than 3 months, the 5th edition of the Athens Soldier Course will take place after 1 year of absence due to the pandemic. For this time period, we wanted to stay connected with our colleagues, with our international friends, and thus we came up with the idea of launching monthly webinars dedicated to shoulder pathology and treatment, the Mini Battles E-Series. So, counting down to the next Athens Soldier Course, we hope to welcome you and host you live in person in Athens in next May. Registration are open, and for more information, please visit our website www.athenssoldiercourse.com.
So, let me welcome you as well in this mini battle series. I am Manos Antonogiannakis. I am the chairman of Athens Soldier Course. And 2 years ago, after the end of the 4th Athens Soldier Course and our decision to postpone the 5th Athens Soldier Course, we decided to have this mini battle series every month as a connection with our friends and an opportunity to discuss interesting shoulder topics. And this went on till now, and now we are organizing the 5th Athens Soldier Course in May, waiting for you in Athens. And this mini battle is the first time that I'm not going to be the moderator, but I'm going to be a presenter, a guest presenter. So I'm going to leave to Manos Brilakis the moderation, and we can start.
Thank you, Manos. Before introducing our guest, please take a moment to vote for our first question, which is the following. During the last 12 months of your practice, in how many cases of chronic posterior superior rotator cuff tears you have augmented your repair with a graft or with SCR or with a subacromial balloon spacer? And your option is never, in up to 50% of the cases, in more than 50% of my cases, or always. Please take your time and answer. Today's episode is three episodes until the main course, and it's dedicated to chronic massive rotator cuff tears with functional shoulder. And with us, we have four very dear friends and exquisite surgeons. Professor Dr. Rob Hartzier from the San Antonio, Texas, clinical assistant professor, sports medicine fellowship program at Baylor College of Medicine. Alexander Ladermann, shoulder and elbow surgeon from Latour Hospital. Dr. Antoon van Raebroeckx, president of BELS, Belgian Elbow and Shoulder Society, shoulder specialist, shoulder training and research center. And of course, Dr. Manos Antonogiannakis, the chairman of Athens Shoulder Course, the director of the third orthopedic department of Υγεία Hospital. Remember that throughout the mini battle, you can also submit your questions. And so, without further delay, ding dong, let the mini battle begin. So,
well,
proceed with your lecture.
Yes. Hello, everyone. It's a real pleasure to be here. I appreciate the invitation, and it's always fun to discuss these bad rotator cuff problems here. Manos, am I on now?
Yes, we can see your presentation.
Excellent. So our topic today, chronic massive rotator cuff tears with functional shoulder. I have the pleasure of arguing for repair and augmentation with a graft, or SCR. I do have some financial disclosures that are potentially relevant to this debate. In fact, since I'm working with Stryker as a sports medicine consultant, I probably have the most potential bias in favor of the balloon now that InSpace has been acquired by Stryker, and we have this FDA approved in the US, but I'm arguing on the repair side today. In terms of non-financial disclosure, it's important to acknowledge Steve Burkhardt, who is my mentor and whose practice I took over here in San Antonio, where I'm presenting from. And clearly, you'll notice in this talk that he's influenced my thinking and practice the most out of everyone who trained me in terms of treating massive rotator cuff tears. So a couple of opening comments. This is an excellent debate topic. I think it's very relevant in all of our clinical practices. It's been proposed in a narrow enough way, I think, that we can have a great discussion and hopefully sort out some issues in treating these patients. The argument that I'll propose today is in an era of increasing options for non-reparative or reconstructive surgery and taking care of bad rotator cuff problems, particularly the InSpace balloon in reverse, that we should not easily abandon repair and reconstruction for these patients. And I'll go through 4 sections here, my case for rotator cuff repair in this situation. So why is this such a controversial topic? First of all, we don't always agree on the terminology and what is the actual pathology and the patient descriptions that we're treating. The patients and the pathology present on a wide spectrum. Sometimes we have, in fact, too many treatment options really in taking care of them. There's complex decision-making, both in the office and in surgery. There's technical complexity in these operations and others. In fact, in our debate topic, I'd like to suggest that we don't really even have a very good definition of what is a chronic rotator cuff tear. If we go into the latest edition of Rockwood's The Shoulder, the 22 edition, then look for what is the textbook definition of a chronic rotator cuff tear. We won't even find one. So are we talking about atraumatic tears here? Are we talking about time from onset of symptoms to surgery or presentation? Are we talking patient age, imaging findings? it's really very unclear. The closest thing that we get is this kind of statement: existing research has attempted to segregate rotator cuff pathology into acute or chronic. Often this is not clinically accurate and neglects acute on chronic changes. So what are we really talking about here? When I think about these patients, I'm thinking of a patient with a rotator cuff deficient shoulder. This means no matter what treatment we propose to do for them, they are going to have some form of rotator cuff deficiency, whether that's muscle dysfunction or unrepaired tendon, some degree of degenerative change. And in taking care of rotator cuff deficient patients, which is the best solution for each one? I think that this case is illustrative of what we would be thinking of in a chronic, massive, but functional rotator cuff tear patient, someone who has some early degenerative changes, maybe some proximal migration as you see here, but who has good range of motion and weakness. And when we take a look at the MRI for this patient, we see a very large and retracted rotator cuff tear with atrophy and fatty changes of the posterior-superior rotator cuff muscles. If we look really closely here, though, we see, if we look at the coronal images, maybe that muscle isn't quite as bad as it would appear on the one sagittal cut. So for me, taking care of this kind of patient, it matters a lot who they are. Are they young? Do they want strength back from their shoulder? What is the entire clinical picture? So I mentioned that we have so many options in taking care of these patients. The way that I think about this is divide into joint sacrifice and joint presentation. So we can give them a reverse prosthesis. We can preserve their natural glenohumeral joint surfaces with debridement or partial repair, heroic type of repairs with medialization of the bone bed or interval slides, fancy repair constructs to try to improve healing, possible augmentation or SCR, the balloon, all of those kinds of joint preservation options. Then within joint preservation, I try to think of this as, am I trying to go for some kind of repair or reconstruction, meaning partial repair, heroic repairs that I was mentioning, augmented repairs, SCR, bridging reconstructions, or am I going to abandon trying to repair their rotator cuff, either debridement alone or a balloon spacer? So the argument today is, should we try reparative reconstructive type of surgeries, or should we just drop in a balloon? So I think that I have a more difficult argument today, because what I'm trying to make the case for is operations which are technically difficult, take a long time, and are slow to recover for the patient. They require patient and surgeon both to be very patient. Whereas on the balloon side, we have something which is technically easy, which is short in the OR, and which is potentially faster to rehab and potentially safer also. So to win the debate today, I have to demonstrate that there is some benefit to the patient for rotator cuff repair, reconstruction, plus in terms of strength to the patient, pain relief, durability of the reconstruction, versus abandoning their cuff to debridement or the balloon. So again, my argument, in this world of increasing options for cuff neglect, we should not so easily abandon repair and reconstruction. And one trend that I think that is noteworthy is these patients are so complex sometimes that we tend to rely on heuristics or rules of thumb in deciding what to do with them. So heuristics are like aids to our decision-making that help us when we're facing time pressure or complexity. And we should, I think, stay away from these kind of rules of thumb where we look at one imaging finding or one examination finding and make the entire determination of the patient based on that. Just because the patient has bad rotator cuff disease does not mean that we need to sacrifice their joint or abandon rotator cuff repair. So for me, what I like is a full toolbox with lots of different options to take care of the individual patient. So I've looked recently at my massive cuff surgery practice and what have I actually done with these bad rotator cuff tear problems. And I've wondered a little bit if maybe I should be following my own advice more, because in a little over a third, I've actually used reverse prosthesis for them. So hopefully Dr. Burkhardt isn't watching this presentation at some point. But in my joint preservation practice, so the patients that I didn't do reverses on, most of the time I actually just did rotator cuff repair. So there are some tendon transfers, there's some SCRs in here and partial repairs, but most of the time I just actually repaired the rotator cuff. We looked recently in doing a value analysis between reverse and SCR at our institution, who are the patients without arthritis with massive rotator cuff tears that we actually selected them for reverse shoulder arthroplasty. So of that group, which I was mentioning in my practice, over a third, they tended to be older patients. They tended to have more prior rotator cuff repairs, lower baseline functional scores like ASES score, higher homogrades, higher rates of pseudoparalysis, and high degrees of fatty infiltration of their rotator cuff. So these were bad rotator cuff problems that I'm selecting for reverse. And probably for me in my practice, these are the patients that are going to be also somewhat more selected for the balloon patients who have the worst kinds of rotator cuff problems that I would reluctantly go for reverse for them, particularly patients who have preserved range of motion. But like all studies of reverse, we accept there's a fairly significant rate of major complications. In this study, 13%, including acromial fractures, instability, and other things. So we have to be careful about joint sacrifice and rotator cuff problems for this reason. So for me, if I select a patient for joint preservation surgery, I attempt to repair their rotator cuff. So that is something which Dr. Burkhardt really impressed upon me when I was a fellow, and seeing his patients since his retirement and in my own practice, I have found that this is a principle which really holds true. So for patients who we select for arthroscopy for these bad rotator cuff problems, the decision for irreparability is made intraoperatively. We don't decide to abandon their rotator cuff until we have tried to repair it. So on this principle, we might ask, well, how really hard should we try to repair their cuffs? What should we do if we're unable to? Because obviously not all rotator cuff tears are repairable. How often are we actually going to be able to achieve that repair? And is it successful? Is this beneficial for the patient, this treatment approach? So in my practice, for these patients with bad rotator cuff problems, I schedule a long operation for them so that I have time to use all of Dr. Burkhardt's tricks to try to get them repaired. So I try hard to repair them. So in this kind of patient, you look at their MRI scan, they have a massive, very retracted tear, some degree of fatty infiltration. We start to assess their rotator cuff. It doesn't have very good mobility. You can see that it's going to, without doing something, this is going to be a repair under pretty significant tension. But if we use all of Dr. Burkhardt's tricks, if we use an anterior slide, a posterior slide, then for this patient who happens to be young and active and just neglected their rotator cuff problem, we get excursion, which will easily result in a double row repair. So going from something that looks irreparable to something which you can get a double row reconstruction on. We can't neglect the subscap in these kind of rotator cuff problems. So even though this is a lecture on posterior-superior tears, the subscapularis is very important in these massive rotator cuff tears. So this was a revision case. The subscap was neglected the first attempt at repair. Now, if you see that if we repair it, we can use margin convergence techniques and get an excellent link double row repair again when it seemed like this would be possibly irreparable. Margin convergence we shouldn't neglect. This is another tear which is a revision situation. The patient fell after a link double row repair and has something which looks terrible. It's revision, it's retracted, it's massive. There's some degree of fatty infiltration, but if we properly assess the mobility of the cuff edges and do margin convergent suturing, then you'll see that this repair starts to look very repairable, and we can actually get, in the revision setting, another link double row repair. So another patient who is young and needs a durable reconstruction, which gives them strength back. So we should not give up on the rotator cuff in this kind of situation just because the preoperative imaging is bad. So if we have this philosophy that we're going to really try to repair their rotator cuff, how often does that actually happen? So in Dr. Burkhardt's practice, and this included the beginning of the SCR era, we looked this up, and there were 88% of massive cuff tears which were fully repairable. The imaging, preoperative imaging, there were associations between irreparability and the preoperative findings, like a tangent sign or Goutallier 3 to 4 changes of the supraspinatus, but the positive predictive value wasn't that high, so it wasn't that predictable bad-looking preoperative imaging. The majority of the tears were fully repairable, even though they required advanced techniques in most of the cases. So I thought it would be interesting to look up in my practice for my patients who I actually scheduled for SCR, meaning they were scheduled for a long surgery time at a different hospital that we do SCRs at than our surgery center. And in other words, we anticipated doing SCR. How many of those did I actually repair? And it was the majority. It was 60%. So what happens in these patients? Is this surgery successful for them doing heroic rotator cuff repairs, even in the face of poor imaging findings and chronicity? So what I've started to pay attention to the most, because all of these rotator cuff repair operations give the patient pain relief. So for me, what I really am concerned about is which is the best option for giving the patient strength back. So if I look at my ASES questionnaires for these kinds of patients, preoperatively, 60% say they are unable to lift 10 pounds overhead. 70% postoperative say they can do this without difficulty at minimum 1-year follow-up. So that's a big improvement in strength for them. And I think that that is a finding which bears out Dr. Burkhardt's philosophy that we can really improve these patients if we are able to repair their rotator cuff. 95% of patients tell me that we met or exceeded their expectations for postoperative strength and motion in this situation. So is this surprising? Should this be surprising to us? So I find this paper very interesting. What if we start to look at the whole muscle instead of just one sagittal image? So in the discussion of this paper, that's Dr. Weiser and Dr. Gerber, we find that in this patient population, which was supposed to be preoperatively only having Goutallier 2 or less of their rotator cuff, they found in the post hoc analysis that there were 4 patients that had Goutallier stage 3 as graded by the radiologist. So they were supposed to have 50% fatty change. The maximum amount that they had was 19%. And I think that this is something that we're going to find more and more in the future, that Goutallier grade overestimates the degree of fatty change in the rotator cuff. And it is a marker a lot of the time of retraction as much as fatty degeneration. Dr. Burkhardt found this a long time ago, even in the era of single row arthroscopic rotator cuff repair, that if you repair patients that have 50 to 75% fatty infiltration on their infraspinatus on that one T1 sagittal cut, they have excellent clinical outcomes. UCLA score 12 to 32 of 35, constant score 80 postoperatively. You can really help these patients repairing their rotator cuff. Are these reconstructions durable? After 20 years studying open massive rotator cuff tears, very few patients have had further surgery and gone on to a reverse prosthesis. Half of the tears are still repaired, and over half of patients say that their subjective shoulder value is greater than 80. So what happens if I try and I can't get the rotator cuff repaired? So I have SCR as a backup option for patients that have preserved external rotation, some infraspinatus or hypertrophy teres minor. Patients that have no external rotation function, Goutallier 4 teres minor, then they get a tendon transfer from me. So why am I still choosing SCR as a backup in the case of operative irreparability? I think Dr. Mahada's findings at 5-year follow-up are really important. In the case of fascia lata, 90% rate of healing, tremendous improvement in ASCS scores. Johannes Barth found using long-headed biceps for this type of reconstruction produced the best strength in comparison with other massive rotator cuff techniques, and had a very high rate of healing, 100% for the infraspinatus part of this reconstruction using the long head of the biceps. Using dermal allograft in our practice, we found for Dr. Burkhardt's patients, very good improvements at 2-year follow-up, either with SCR used as the reconstruction or as a rotator cuff augmentation under a complete repair. My SCR results have not been as good as Dr. Burkhardt's. I've particularly found that the strength for my patients has not come back as reliably. If I look at my patients' self-reported ability to lift 10 pounds overhead, most patients are unable who are going for SCR, 80%. Only 20% report that it is not difficult for them to lift 10 pounds overhead after SCR. So inferior strength, which we would expect, versus the patients who have complete rotator cuff repair. Met or exceeded expectations for strength and motion, only 62%. So for me, this is more evidence that if I can repair their rotator cuff, I will. Now in the US, what about the balloon? We have the in-space balloon, FDA approved. This is the FDA approval language for massive irreparable rotator cuff tears. For us, it is off-label if it's used in patients who are under 65 years of age. The reason why is because the IDE study that was used to justify this device to the FDA actually found slightly inferior outcomes for the balloon if you age stratify. I think this isn't surprising versus partial repair in this study, because the partial repairs actually were done with a significant number of anchors, and they were real partial repairs. So again, I think this is some evidence that if we can repair the rotator cuff, we should. We know for the balloon that it's beneficial for the patients in terms of short surgery time and safety. And so I think for a subset of massive cuff tear patients, the balloon has a great place. But again, for me, I'm wondering about their strength and the durability of their clinical outcomes. And for me in my practice, I am not going to abandon repair and reconstruction for these patients for these reasons. And I'll yield the floor. Thank you.
Thank you, Rob, for this interesting presentation. Before listening to what Manos has to say, have a look at our second poll question, which is, when performing SCR, what do you prefer to use? The long head of biceps, the fascia lata, an allograft, or you don't do SCR? Take your time to answer, and Manos, proceed with your presentation.
Okay, thank you, Manos, for this kind invitation, and I'll try to share now. Okay, can you see the presentation now?
Not yet.
Okay, now?
Well, yes, now it's better.
Okay. So, after this so nice presentation, and I'm going to discuss about the balloon and what is our experience with this and how we use it in our practice. And rotator cuff functional anatomy is very important because we are trying to restore the function of the shoulder and the function of the rotator cuff. So we must understand that rotator cuff is a functional anatomic unit and not for tendons that are related between them. There's no relation between them. And when we have a tear on the rotator cuff, we see a lowering of the functional reserves of the shoulder. And when the functional demands of the patient exceeds the reserves, then we have symptoms. Otherwise, we have an asymptomatic tear. And of course, massive cuff tears is a problem. There is too many. And with any type of classification, we know that if we have to treat a patient with a massive cuff tear, we have going to have problems. And the important question that we try to answer again and again is why some patients have a rotator cuff tear, even a massive rotator cuff tear, and they don't have symptoms, and others have. And Steve Burkhardt tried to give the first answer, discussing about the stable fulcrum kinematics when we have a rotator cuff tear, but still the couple forces are not disturbed, and the shoulder can function with the rotator cuff. And then the capsular fulcrum kinematics when the fulcrum is under the acromion, the head is capsured under the acromion, and this still gives enough function to the shoulder. And of course, the unstable fulcrum kinematics when we have an anterosuperior escape, when we don't have anymore, the shoulder anymore can function. Sorry. So the next classification of the rotator cuff was the one by Colin, Ladermann, and Valls, and they classified the differentiate the rotator cuff into 5 components. It's 5 components: the teres minor, the infraspinatus, the supraspinatus, and the upper and the lower part of the subscapularis. And they found, and this is common knowledge now, that all cuff tears are not the same. And they classified 5 types of tears. And tears B, C, and E are those that are painful and sometimes, most of the times, produce a non-functional shoulder, either pseudoparalytic or with an external rotation lag. And in type A and B are painful, but still the shoulder is functioning. So when we try to treat a patient with a massive cuff tear, what options do we have? First, we could lower the functional demands of the patient, change his activity, change his lifestyle, and by this way, lowering the demands. Or we could repair the cuff. This is what us orthopedic surgeons try to restore the anatomy, mainly. Or do something else, increase the functional capacity of the remaining intact cuff, mainly with exercise, by physiotherapy. We know that when we exercise the shoulder functions better. Or we could implant the in-space balloon, or we do a reconstruction of the superior capsule, the SCR, where we change the anatomy in order to give a better ability for the shoulder to function. And of course, we could do tendon transfers. So if we have a traumatic acute massive cuff tear, either an acute or an acute on chronic, the first option, the first thing that we try to do is to reconstruct the cuff, to restore the anatomy with all these now principles that Steve Burkhardt and others have pointed out, mainly to balance the force couples, to have stability in the edge, to have a strong fixation without tension. But when this is not possible, what can we do? This is where we are now. And are there unrepairable tears? Yes, they are. And we can suspect from the preoperative check-up and control and have an idea that maybe this tear is going to be irreparable. But the decision at the end is always during surgery. And this was another very nice classification from Davidson and Steve Burkhardt again. And what they showed is that when we have the type 1 or type 2 tears, we could have good to excellent results with repair. When we have cuff tear arthropathy, then we have to go to reverse prosthesis. But in the third type, the massive tears, then we can try many options and have good results. And this is what we are discussing now. And the question is, where can we use the in-space balloon? What is the in-space balloon? It's a spacer. It is a copolymer of polylactid and caprolactone. It is biodegradable. It's absorbable, completely absorbable over a period of 12 months. It's a very easy technique, easily reproducible, and practically you just debride the space, and then you measure the dimension of the space, and then you can implant the balloon. It's compared with all other options that we have for massive cuff tears, excluding debridement and tenotomy and simple tenotomy, is the easiest thing that we can do. We came in contact with the balloon something like 7 years ago from this first study from Vladimir Senekovic and Robert I. Kovacic, all these friends of ours from Slovenia. And they presented the results of short-term results that were very satisfying. And so we came in contact with them. And then there were many studies in the literature about the biomechanics of this study. A very interesting of this balloon. A very interesting one was the study of Chevalier, who measured the pressure in the subacromial space when they implant the balloon, and so that there was a better pressure distribution to the rotator cuff, either after a repair or without a repair. And also this very interesting study, biomechanical study from C and Sai and Reeves, who compared the results of the balloon, what happens when we implant the balloon or when we do an SCR. And what they found was that they had similar result, the balloon compressing the humeral head from above, the SCR pulling down the humeral head from below. And many clinical studies also appeared in the literature that they showed the result, that the results of the balloon were impressive and very satisfactory. And also this is a literature review who also showed that beneficial results. We published our results in 2019, and this was a study of 31 patients that they had a mean follow-up of about 2 years. And the interesting thing is that they have a satisfaction rate that it was about 80%, and about also 8% were pain-free. Now, what we did with these studies, that with these patients, that we tried to repair the cuff, do a partial repair or a medialized repair, and then implant the balloon. And comparing the results, we have satisfactory results, as we said. But the interesting thing was that when we compared the results between the patients that we didn't repair and the patients that we did repair, we saw that the patients that we did not repair were a little better, slightly better. And this was something that was very interesting, because the people that we didn't repair, the patients that we didn't repair, were the most difficult cases, those that we could not repair. Otherwise, we would perform in the other patients, we performed a partial repair or some kind of repair. And still the results were not worse, as we would expect. And then this is another interesting study from Enrico Gervasi, where they tried to implant the balloon under radiologic control, the in-space balloon. And they had good results also, this making even simpler the procedure. Now we are trying to implant the balloon with needle arthroscopy, with the nano arthroscope. We are trying to see if this is possible, and seems to be. And this is going to make the procedure even simpler. Another interesting study, which is from Alex Castagna from Italy, where they tried to compare the implantation of a balloon with physiotherapy and debridement, and with reverse shoulder arthroscopy. And they showed that they had better results with subacromial spacer from simple debridement, and they had also, it was less costly to do than a reverse prosthetic, taking into consideration complications and all this. Although these studies are very affected by the logistics and the economics of the national health systems, and they are not applied. They cannot be applied to all the countries. It's still an indication. So, in conclusion, we have a very easy technique with very promising results. And this is a patient before surgery. This is an inability to raise the arm due to pain. It's not, we can't show his face, but you can see that the pain is stopping him. And this is the follow-up at 1 year and 2 months. And this is the follow-up 4 years later. So why this is happening? Is it because we do a repair or due to the in-space balloon? And we try to do a prospective study where we compare the results of 25 patients. It was a blind study, double-blind study, where we implanted the balloon and then we followed the patients, 25 patients. We do a debridement or partial repair depending on the condition of the rotator cuff and our ability to repair it. And at the end, we put or didn't put an in-space balloon. And these patients were followed for about 1.5 years, mean follow-up 1.5 years. And we have very satisfied patients or satisfied patients. And what we saw is that the results between the two teams of patients were the two groups of patients were similar, and they had an improvement in all the scores. So what we could not show a difference by implanting the balloon after a repair, but we could not show also a difference between if we change the question is why would repair just not implant the balloon? And so now we are trying to implant the balloon in patients that they have pain as their main complaint. They are able to and motivated to rehabilitate. This is very important. And their restricted range of motion and the loss of function is a result of pain. And when we have a painless pseudoparalysis or a painless loss of power, we had the worst results. What we think now is that by implanting the balloon, we're starting early rehabilitation, functional rehabilitation, and we try to convert a symptomatic to an asymptomatic cuff tear. And what we see is that patient selection is very important. And we had two types of failure. Patients that continue to have pain after the implantation of the balloon and the rehabilitations, and patients that they came with a complaint of their main complaint was the loss of power before the operation. They still complained after the operation. So the balloon is for pain. It's not to restore the strength of the shoulder. So our best indication now are older patients that they have a massive cuff tear that it's painful, but still they have a functional shoulder. And any limitation that they have to the range of motion to the strength is due to pain, not painless. And the patients that they failed conservative treatment. And in these cases, we know that we have a minimally invasive technique that is not burning bridges. Thank you for your attention. And I hope that we are going to see you at the 5th Athens Shoulder course.
Thank you, Manos, for your thorough insights. Before its lecture, you asked to vote, and the result is that in the first question, the 6% never use some augmentation of the posterior superior cuff tear as a repair. And in the second question, 23% use the long head of biceps for SCR, 23% an allograft, 15% fascia lata, and 40% don't use SCR. So, Alex, Antoon, I would like your comments on those that we hear.
Okay, first of all, thank you for the invitation. I think it's a great discussion and really a hot topic. If you allowed, I just would like to, Rob, welcome back. So Rob, I was saying that I think it's a great discussion, and if you agree, I just would like to share one case. This case is coming from America, but it's South America, and it's an insurance. ask me to show it. So I think that, do you see my screen now?
Yes, Alex.
Yes. Okay. So this is something like a 60 years old patient that had a shoulder dislocation, and she has been operated by a surgeon in South America. And I'm not going to read everything, but you can see that obviously it was quite tough. He did a superior capsular reconstruction because everything was irreparable, obviously. He used quite a lot of anchors, 8 anchors for the superior capsular reconstruction, and then he tried to reattach some tendon in the back. So at the end, it's 11 anchors. And finally, because it was not expensive enough, he added a subacromial biodegradable balloon. So after 5 hours, these surgeons spent something like $9,000 for a patient that clearly remained after 1 year pseudoparalytic. And this story, I heard this story 10 times, and this is the images of this patient, and you see that he completely missed it's a dislocation of the tendon into the glomerular joint. So this has been missed. This has not been repaired. And obviously, this patient would have probably had a better result with another solution like a reverse shoulder arthroplasty. So it was just to show you that from time to time, we are completely crazy in this world. I just would like to share one more share. Yeah. So we published this study in 2018, and it's not the best study ever. It's a review study, but we compare some quite easy surgeries like biceps tenotomy, partial repairs, with superior capsular reconstruction or the balloon, and biological augmentation, reverse, and so on. And if you have a look to the preoperative score, it's very interesting because they are almost all the same, except for the reverse that is lower, but it's almost all the same. And at the end, whatever you do, you end with scores that are almost all the same. But what is interesting is the radiological failure rate. If you just do a tenotomy, you don't have failure, so it's 0%. If you do a superior capsular reconstruction in the hand of a good surgeon like Patrick Donald, it's between 55 to 70%. 70% in the last study that I published with him. And for the balloon, it's 100%. So is it really worth to spend all this money for a result that you could obtain with maybe simply a partial repair and a biceps tenotomy? I'm not sure. I don't have conflict of interest, but I will be interested to hear you. And my last comment will be, so I can close it. I'm sorry for this. I can stop to share my screen. Yeah, so I can stop to share my screen. So what do you think about it? The only comparative study I know between a superior capsular reconstruction and a partial repair is the study done by Greiner. And interestingly, the partial repair is doing better. So it's easier, you spend less time in OR, there is less complication, and it's less expensive, and you have better result. What do you think about it, guys?
Yeah, I've wondered, Alex. I mean, I can start if we have given up too easily on partial repair. And when I read the literature on partial repair, I find the outcomes to be encouraging and the results fairly durable. And so my response, I guess, my own playing devil's advocate for SCR is that there are starting to be some longer term, particularly autograft SCR results that it you could imagine that they would be, as a biological reconstruction, more durable over time. And perhaps for some patients, it's worth it to spend the money to do and the time to do that. But I don't think we know that answer yet. But that's one potential argument for continuing to do that type of reconstruction.
So, Rob, I agree with you. First of all, we are coming from the same school, and as you, I really spend time to repair everything I can, and I have to admit that most of the time, the cuff is repairable, and I'm like you, I repair everything that I can. Regarding the allograft, what you say is really interesting, because even if the result of Miyata are absolutely unbelievable, because 92% of ESC score, it's my patient in a normal state that don't have any shoulder problem, don't have 92. So this is really unbelievable result. However, I think that the concept with the autograft is something that I could believe in. We began with the supercapsular reconstruction with xenograft, and this has been abandoned. And now I think that with xenograft and with allograft, the results are not so good. So maybe, as you say, allograft, like it has been proposed by Miyata, might be an option, but again, there is no prospective comparative study.
That's true.
But in our experience here, we start with the idea that tenotomy and debridement is very effective, but it's not always effective, because we had patients that we did a tenotomy, we did a debridement, and still they had pain, or they had a traumatic tenotomy, and still they still had pain, and Popeye deformity, and still had pain after that. And then what now we think is that we need something that is going to allow early rehabilitation. And I mean that the most important thing, if we want the shoulder to compensate, is to try to exercise what we have, the deltoid, the whole, the remaining calf that we have. And what is stopping from exercising is mainly the pain. You have to find a way to stop the pain for a period in order to start the shoulder exercising, and then to gain again the ability to compensate for the distorted anatomy. And this is what the balloon, the philosophy of the in-space balloon was that you implant the balloon and then you start immediately the rehabilitation. You don't have a period of keeping the patient inactive, something that disorganize the function of the shoulder, the ability of the muscle to cooperate and compensate for the problem that they have. And so we started implanting the balloon. We try to do a repair. We started implanting the balloon, and then we hoped that this would allow for a better rehabilitation. We saw that we had a quicker rehabilitation. We were allowing more activities and quicker in the patient. And then we didn't see a worsening in the results, either in clinical results or in the MRI and all this. We had still a number of patients that did not heal what we did, but it was not worse than before when we followed a more restricted program. And this changed our philosophy of how we're treating now calf tears. We push the situation for as soon as possible to regain motion, to regain function. and hoping that in this way we are going to have more satisfied patients. The problem is that the reverse shoulder arthroplasty is a very effective operation, but the impression is that in some cases we are over-treating patients in this way. For example, we have a patient that is 70 or 75 years old, and he's coming with pain and has pain for 6 months, say, duration. And then, okay, what we do? Shall we repair the calf, the massive calf tear? Well, maybe it's too much. Shall we start only with rehabilitation, do cortisone injection and all this? Most of the patients, when they come to us, they have already done this, and it was not effective. And so should we go for a reverse?
Not to mention that, so it may be too much surgery, even in the best case scenario, but you're also subjecting those patients to potentially really serious complications. That
yes,
the other options, because that's the difference. I mean, Alex, I take that point very seriously, that it's hard to tell a difference between a lot of these operations, but it's very easy to tell the difference between the complications of a reverse shoulder arthroplasty and a balloon, which is none almost, or a partial rotator cuff repair, or some, even heroic rotator cuff repairs have very few serious complications.
Sure.
So we all agree that the first goal is to repair the calf, but there are cases that the calf is not repairable, or the calf is not, the quality of the calf is not so good. So, Antoon, what is your preference for the posterior superior calf, the posterior superior calf tears that you are not satisfied about the tissue quality? What do you prefer to do?
Well, I think there's two different cases, and I love Rob's presentation where he still tries to do the partial repair. And we are getting more and more interest in everything around the biceps. We're changing a lot of our practice. Before, we just cut the biceps and we debride it and we had good results. And now we're doing completely the opposite. We're using the biceps, actually trying to centralize humeral head. So that's a philosophy which is completely turning around, and we've got nice results in both cases. But I think maybe the indication might be a bit different if you got still more active patient with a massive tear and there's still a biceps. I think in those patients, I think using the biceps to stabilize humeral head, we call it a bit more reconstructing the interval, actually, because I think the rotator interval plays a big role in the last part of stabilizing humeral head. And what we do by using the biceps is actually recreating the rotator interval. Biceps just runs underneath the superior glenohumeral ligament. So I think we were gaining a lot of interest in biceps using in this type of patients. We're following up our patients now with the use of the biceps, where we don't cut the biceps, not proximally nor distally, but we're just lifting it out of the groove and fixating it on the greater tuberosity on top. And if possible, we try to do a side-to-side repair of infraspinatus to the tendon. So without cutting the biceps at any place. And we see nice results as well. So I think in patients where the biceps still in place, I think biceps can be a very nice solution to get rid of the pain, because everybody's saying that the major indication is the pain. So for pain control, we like that. And another thing is that's a very cheap solution. It's very economical. And in Belgium, in 2 weeks, I'll be negotiating for 3 weeks with the government because of the payment of what we're going to do. So I'm afraid that in the future, if economics going to hit us, that we're going to choose for maybe less expensive options than the balloon. So these are my 2 remarks. I think the biceps is very interesting, and economics, at least in Belgium, is going to play a big role in defining what we're going to do. Alex,
yes.
Antoon, 2 questions. One question to you, Antoon. You said that you reconstruct the rotator interval, but where do you put your biceps? You let it in the groove, or you put it on the greater tuberosity?
Yeah, I understand your question. I'll lift it just outside the groove. The only reason why I do that is then it's easier to access it with the remaining parts of the rotator cuff in the back, because the idea is still to stitch the remaining of the rotator cuff to the biceps. That's why I bring it a little more posteriorly. I'm not sure if it makes any difference in just leaving it, but it's just to be able to fix it side to side.
And you don't cut the bicep distally.
Never.
You
Nothing.
just let it in continuity.
Exactly.
And you, Manos, you said, Manu, that if the cuff is really bad and you put a balloon, it's even better not to repair the cuff. But do you cut the biceps or not? Or you even let the biceps?
There are two phases. In the first phase, when we did the studies, what we did was to do a tenotomy of the biceps and then do a partial repair and implant the balloon. We were expecting that patients that we had a partial repair would be better than those that we could not repair at all the cuff. It was, if we could repair. If we could not, we didn't repair. But we saw that the results were a little better in those patients that we did not repair the cuff. It was good results in both groups, but those with not repairing, it was a little better. And remember, there was a selection of the patients that were patients that they had many problem of pain. It was not the painless loss of strength or the patient that was coming complaining mainly for loss of strength of the shoulder. And then we passed and started doing superior capsule reconstruction. And we saw that we're using the fascia lata mainly. And we saw that there were about 30 to 40% that fascia lata, the fascia lata was ruptured in the MRI 6 months later. But the patients were still good. We were still well. We were functioning well. And then we start using the biceps as Antoon showed, and we try to repair the cuff to the biceps, either leaving him on the groove or taking out of the groove and putting just next to the groove. And what we saw is that the biceps remained attached. Many times the part of the cuff that was repaired to the biceps was ruptured again, but we had a tissue in front and behind, the infraspinatus and the interval with subscapularis, and the patient was functioning very well, and he had also increasing strength, the strength of the shoulder. So now, when we do a superior capsule reconstruction, we use the biceps. It's very easy, as easy as the balloon, and it's much cheaper. It's just an anchor. Increase the cost by an anchor. And it's something that when we say that the balloon is a very easy technique to do, what we have as an analog is that you can do the superior capsule reconstruction with the biceps, and it's easily also and very quick to do it. So we, most of the time when we repair the cuff, massive cuff tears, now we are doing something like this in order to augment the repair. I think this is important, and this changes the results also.
And you,
However, I would like to share my experience on this. I start to do the biceps to move out the biceps from its groove and saturate, like Antoon described earlier. However, in one patient, after a supination move, after 4 days of the operation, he sounds a pop, and then the pain stops. And for my opinion, the biceps came into the groove again. And from then, I asked every patient that did the same, and one other patient described the same feeling. In the supination move, he felt a sharp pain, and then he stopped the pain. And I think that removing the biceps from the groove, from now then, I also cut the biceps distally if I do this. So I don't believe that removing the biceps from the groove without cutting it either distally or make the biceps tenotomy, I have some doubts if it works.
Yes.
Rob, you were in a lab during the last years of your practice, so you saw everything. You saw the xenograft, the allograft. What is and probably now the autograft? Do you use the bicep from time to time, Rob?
I like the biceps.
Yeah, me too. What is the future according to you? Is it the fascia? Is it an allograft or an autograft? And if it's an autograft, biceps, fascia lata, what is the future according to you?
Yeah, I think for me, if the defect is too big, then the biceps in some cases can give you a reasonable amount of tissue, but it doesn't restore complete continuity. So I would love to have more availability of autograft tissue, which was larger and easier to harvest. I don't know how to answer your question, Alex. It's autograft of something.
Okay.
Alex, you've got any experience with triceps tendon? Roger van Riets is one of our colleagues, elbow surgeon, and he described in an article that distal triceps tendon might be a good idea to use as a graft as well. Have you got any experience with that? I did it once, but I don't know.
I don't have. If the biceps is here, I just use the bicep. If it's not the case, I find something else. To tell you the truth, I never did a superior capsular reconstruction of my life, except with the Achilles tendon when I reconstruct the bone as well. So I use the calcaneum to reconstruct the proximal humerus, and then the Achilles to reinforce the cuff, but it's not a true superior capsular reconstruction.
Alex, what do you think about, so if you have a perfect outcome in the ASES score, but you report you're unable to lift 10 pounds overhead, then your score is 95. So
like all my patients,
I would like to know in more studies what the specific results of questioning the patient on their functional outcomes are.
So to answer truly your question, for me, the best scores are the SSV, and this is for the cuff, and for instabilities, the score that we published in 2020, it's the sane instability, exactly the same, but we ask the question for the instability, and there is an unbelievable correlation with all the complex score that use strength and so on that you can imagine.
Yeah, I agree there's a correlation, but if we're also going to ask them other questions, shouldn't we report what they say back to us? Because that matters to me. If someone keeps complaining of their outcome because they are unable to lift 10 pounds overhead, and I knew that that was the result of some operation, then I would not offer that to a patient who wanted strength. Do you understand what I'm saying? Like, we have all of this information in the world that we're not analyzing. Why is that? That's what I want to know.
That's a good point, and we should stop to just to give a result of the constant score, but we should give all the details because there are a lot of important things in the details, I think, like internal rotation and so on.
But the purpose of what we're doing here is the pain control now. Both presentations started with the biggest problem is the pain because it's still functional. So.
Yeah, but my point in my presentation is I think that I can give, in many cases of chronic rotator cuff tears, better strength back by repairing. That's the point for me. So I think it's worth my time in the patient rehab to try to achieve that goal, even if the MRI imaging doesn't look so hot. I think in the future, one future of massive rotator cuff surgery is we're going to use a lot more information than one sagittal T1 image in our decision making.
We tried to see the reasons of failure, why the patients were dissatisfied with the operation. And what we found was that the patients were dissatisfied. There were two categories. First, they have pain, and those patients were very dissatisfied. Second, the patients that they had loss of strength and they were coming to the operation with the expectation of increasing strength. If we had this type of patients, these patients will continue to be dissatisfied. Those patients that they were coming for pain and have also some loss of strength, when they stopped having pain, they didn't consider the loss of strength an important issue. So it's very important for the end results and the satisfaction of the patients is the how you decide when to operate, to whom, what kind of operation to do. And the expectation of the patients are very important. It's something that we have to, when we examine the results and say that we have dissatisfied patients and all this, we have to see from where we start. What were the initial expectations of the patient before the operations that we offered to him? And we never do a balloon now and this type of surgery to a patient that is coming and he is complaining mainly for the inability to, for example, raise 10 libras. And this it's going to be a failure. We know that now. It's going to be a failure. In the initial phase, I was hoping that by implanting the balloon, I would have a better healing of the calf, and then having a better healing, then we would have better strength. But this didn't come true.
And Rob, I'm following all my patients after rotator cuff repair. I see them at 1 year with a ultrasound, and I can guarantee you that almost none of them that has a perfect heel tendon, Sugaya 1, has the same strength than the contralateral side, even with a native cuff and a perfect repair. It's absolutely rare. So the strength is a big deal. Manos, it's your turn.
The discussion is very interesting, but in Europe is night, but in the USA is working hours. So Rob should continue his clinic. So it was very nice to have you with us, all of you, and we are thankful for this. Well, this is the end of the mini battle. Thank for the attending of the participants. See you in the next episode in March, dedicated to anatomic shoulder arthroplasty for osteoarthritis with a preserved calf. You can always follow the Athens course on Facebook and LinkedIn to stay in touch. And of course, you should follow BMed because there are many interesting webinars hosted in the forthcoming period. Thank you once again for attending. Thank you for participating. Have a nice night.
Thank you.
Bye-bye.
Bye.
Bye, guys.
Have a nice time.